Hello, everyone. It's Dr. Nicole Rochester, founder and CEO of Your GPS Doc. So for those of you who have been following me on my Facebook page, you know that for the entire month of January, we have been talking about dementia. Why dementia? Because it is incredibly prevalent. And I personally dealt with this with my late father, and I have just seen so many friends and family members and colleagues impacted by this disorder. As a physician, a pediatrician, I realized when my dad became ill that I really didn't know a lot about dementia. And surprisingly, a lot of my colleagues, whether they're pediatrics or even internal medicine docs, I think don't know a whole lot about it either. I think it's a very elusive disease, and it's just something that many caregivers across the country will deal with either now or in the future. So it was really important to me to cover that topic in January. And so now the culmination of the entire month is this interview with Dr. Kendra Sheppard. So I am so excited to have this conversation with Dr. Sheppard and for you all to benefit from her knowledge and expertise. So I'm going to start with just reading a little bit from her bio, and then we're going to go ahead and get started. So Dr. Sheppard, thank you for joining us today. Really appreciate you. So Dr. Kendra Sheppard is a board-certified internist and geriatrician. She has more than 10 years of experience in geriatrics and long-term care. She completed her medical training at Meharry Medical College in Nashville, Tennessee. She did her residency in Louisville, Kentucky, and she also did research fellowships at the University of Alabama at Birmingham. And similar to me, she left an academic career to start her own company. So in 2018, Dr. Sheppard launched Sheppard Consulting Services, LLC. And through her company, she provides compassionate care geriatrics in community long-term care facilities, assisted living facilities, and also through house calls. Yes, you guys, there are still doctors out here doing house calls. So welcome, Dr. Sheppard.
Thank you so much. Thank you so much for having me. I just wanted to say that I did both my clinical year in geriatrics at UAB and then did a research postdoctoral fellowship. But
Awesome.
I'm honored to be on this program.
Thank you. So do you have, that's your formal bio. Do you have anything else that you'd like to share with the viewers before we get started?
No, what I would like to share though is to let people know that they are not alone, that there are people in the healthcare field and space that is knowledgeable about geriatrics. We are few in number, but we are working hard to what we call geriatricize the community and the nation at whole. And we're going to need your help with that.
I love that term, geriatricize. I like that. Excellent.
Yeah.
All right, well, let's go ahead and get started. So you mentioned that you did a year in geriatrics, and I know that a lot of the lay public, they probably heard the term geriatrician, but because you all are so few in number, many really don't know what it is. So let's start with that. Can you just explain to us what is a geriatrician?
Yes, so a geriatrician is a physician who specializes in the care of older adults. And so what happens is generally people do a primary residency in internal medicine or family medicine. And in family medicine, it's still a certificate of added qualification. In internal medicine, it is actually recognized as a subspecialty of the board. And during that additional year, you get a lot more experience with what we call the syndromes of medicine. So it's not just disease-based, sort of at your primary level of internal medicine, internal medicine and family medicine. You get to know what my colleague Barrett Bowling said, the facts. So you learn how to treat diabetes and heart failure and COPD and sort of like the medical management of things. But in geriatrics, what you do is you get an extra layer of an extra layer of training on what we call the syndromes, and dementia is one that's the biggest one. But we also learn about falls and incontinence and behavioral disorders and polypharmacy, and incontinence is another big one that affects older adults a little bit more than the general population.
Awesome. Awesome. So, I remember when my dad was still alive, my sisters and I tried to transition him to a geriatrician, but he was super, super loyal to his longstanding family practitioner. Yeah. And I think most of the older people in my family are being managed, like you said, by an internist or family practitioner who doesn't have that additional training in geriatrics. And so while I have my own opinions and feelings about why you all are so important, I'd love for you to share with the audience, what is the advantage of having a geriatrician take care of your aging family member?
Yes. So the unfortunate thing, Dr. Rochester, is that we are few in number. There are less than 7,000 geriatricians in the country. And so it is actually a workforce issue. Some of that, I'm going to try to stay off my soapbox on why there are so few geriatricians. And so what I would say is, there is value there, but geriatrics has not necessarily made the business case for geriatrics the way palliative care did.
Yes.
We're friendly with the palliative care. So, when you talk about the business of medicine, we live in a very youth-oriented culture. And so, people don't want to talk about it, until it happens to their loved one. And then we had a lack of education, even at the medical school level, when it came to taking care of older adults. So when I was coming up through medical school, many internists and subspecialists were like, well, I'm a geriatrician. I take care of older adults older than 65. But we all know it's a lot more than that. Yes. And so at the base of things, it's just a small number. And I would say also in this climate of medical student debt, that people don't always see it as an attractive career. Mm-hmm. However, you really can make a nice salary as a geriatrician. I'm talking to a pediatrician, and when I realized, I was like, wait, I make more money than a pediatrician,
No, we're at the bottom, okay? Peds at the bottom.
And I was quite amazed at that. And so I absolutely, I'm going to segue a little bit. You have a question related, but I'm going to just say, what we've done is, what we try to do is, we really try to train the existing professionals that are out there. Because older adults, especially, we're moving into the baby boomer world now, but even with the greatest generation, they are so loyal to their medical team. And they're like, I've been with this doctor 30 years, I'm not leaving. This person knows best, and so what we're trying to do is, well, let us get the geriatric principles out there to existing doctors that are out there in the field.
I love that. I love that. Well, if you are, I'm in the DC area. And so, we actually have, I'm not going to say a wealth of geriatricians, but there were some options that my dad could have chosen. But let's say for those watching that are in an area where they do have access to a geriatrician, are there certain warning signs or red flags where if you're a family member of, that particular person, you really should consider a geriatrician? And this is not to disparage internists and family doctors.
Absolutely not.
But absolutely. Are there certain things where you as a professional would say, yeah, this patient probably would benefit from the expertise of a geriatrician?
Yes, so I would say there's a number of categories. One is memory loss is a big one, right? So geriatricians tend to be in large urban centers because you have the academic practices there that can support them. But there also there are some other areas where you can find them, but largely you'll find them in large centers that have an academic setting. And what I would say, the person who needs to go to a geriatrician, it's not age-based,
That's a
in
good point, Dr.
general.
Sheppard.
Yeah, in general, we don't feel that 65 is old. And that's my personal opinion. And I do think that's my professional's opinion. We like to see people over the age of 75. But if you're a 55-year-old that has a very chronic, complex disease, number of diseases, they would benefit from a geriatrician. So the people that I would recommend for a geriatrician, an assessment by geriatrics, is those who are on more than 5 medicines, which is the strictest definition of polypharmacy. Those who have a syndrome where they think it's normal aging, but it's not. So incontinence is not normal aging. I know that people think it is because we have commercials like, I won't say the company, but Whoopi Goldberg, and so I'm like, incontinence is not normal, and a large, there's a few people that have stress incontinence and are treated with surgery, but there's lots of other treatments. I can say that's one area where there's a lot of treatment that we have available. Memory loss, of course, that overlaps, you'll find with both psychiatry and neurology in different areas. And so, I will tell you later how we kind of differentiate from those two specialties.
Okay.
Falls, so for us, the first fall is the time to go to physical therapy, not the third, fourth, or fifth. The number one screening question is, have you fallen in a year? And you do see that now in primary care. And if they've fallen in a year, they need physical therapy now, because when you talk to anyone who's had a fracture, you say, was this your first fall? It's never no.
Yes.
It's always the fourth or fifth. So when you think about that, so people that are complex, that have lots of doctors, lots of medicine, and fragmented care would benefit from seeing a geriatrician.
You just described my father to a T, and I'm sure many other people's fathers and mothers who are watching. Yes. That was so helpful. Thank you. Thank you so much. And I think, one of the things I took away from what you just shared is that a lot of, and we're going to talk about this when we get into our discussion about dementia, but a lot of things are normalized by, even by the healthcare professionals, and the family members feel so frustrated. So to hear you say things like, incontinence is not normal, and we're going to talk about how dementia is not normal aging. And, I really appreciate that. And I think those are take-home points for the audience. Excellent. Well, let's go ahead and segue into the main topic, which is dementia. So I know it's a huge topic, and you could probably talk for an hour just on that, but in a concise way, can you explain to us what is dementia?
Yes, and I'm going to be shorter and have you ask follow-up questions.
Okay.
Just so that I won't go into all of the weeds. So at the simplest definition is memory loss that affects your daily function. So it's not just, oh, I can't remember where I put my keys, or what's your name again? It really is, something that affects function. You'll notice when people, their bills are late, or they get lost in the neighborhood, and you're like, I can't find that, and so, and it's most of the time very gradual. That's important to note. So when we have family members who live away and come home for Christmas and Easter, and it's an emergency, but really this has been going on for several months, and it's just not been picked up.
Really good point. Really good point. And I encourage family members to take advantage of those trips home, during the holidays, to really, start to pay attention to their
Yeah.
family member, to watch how they're interacting, the conversations, how they're moving around, because you're right. Like when you don't see them every day, you may miss some of those subtle signs. And I know even with my dad, I have found that older people, like, they're really good at masking things, when they have
Absolutely.
to perform, so to speak. They will, I guess, muster up all the strength that they have, and they will perform. And then you get
And
them back in their environment and they are a hot mess.
yes, and I will tell you that's particularly common in the South, right? Because you have that very nice Southern lady, and you have had a full conversation with her, and then you realize she's never answered not one of your questions. So that is one of the things that I teach residents and fellows. Is like, well, but you have to ask them, well, what is today's day? You told
Yes.
me springtime, and all of this, and people can deflect, especially in the early stages, right? In the
Yeah.
early stages, because remember, they have some awareness too, and so that's when the fear comes in. They're like, oh my God, my memory. They think about losing their independence and all of those things.
Mm-hmm.
And so what I would say is, let's deal with it early. Why? Because there may be some reversible causes
Mm-hmm.
of dementia. And a big one that people are talking about more and more is medications.
Yes.
And so they're on all of these medicines, and there's a particular class of drugs called anticholinergics.
Mm-hmm.
You know, so our antihistamines, and they have pain, and so they're on a muscle relaxant. And then you put on this other medicine, and they're all foggy and confused, and it's just the medicine.
Mm.
But because they don't know that, they continue to hide, and whatnot. And so that's why it's important to talk about it, and for somebody to recognize it, and don't be afraid, because many times there are reversible causes. And if it's not reversible, it is true dementia, then there are some things we can start planning for and putting in place.
Excellent. So you definitely mentioned memory loss. My dad had vascular dementia, and my understanding is with that particular dementia and some of the other forms, as opposed to Alzheimer's, with him, memory wasn't really a big issue. You mentioned the bills. That was one of the key signs that my sisters and I saw, is that this man had previously been meticulous about his money. I mean, he passed it on to us, and yet when we started becoming responsible for his care, the more we found out, the scarier it got. And one of the things that alerted us were that he had a lot of past due bills and loans and things that my dad would have never done, in his right mind, so to speak. He also had a lot of difficulty with electronics. And that was another thing. That was like a love of my dad. I mean, he was always the first person to buy the latest gadget. And yet he was having trouble going back and forth between like the DVD back to the TV. And he would call us sometimes in the middle of the night and say, I can't get the TV back on. I was watching a movie, but now I can't figure out, how to turn it back to the TV. Can you speak to some of the other symptoms in addition to memory loss?
Yes. So when we talk about other symptoms and the different kinds of dementia, I've heard people say, oh, well, it's not Alzheimer's, is it? And I don't mean to make fun of that, because they feel like that's a death sentence. But
Yes.
really, there are many different types of dementia. Alzheimer's and vascular dementia are really the most common types. So what they share in common is that the memory loss is slow and gradual. The reason your dad sort of had what we call vascular dementia, sort of like a stair step, right? Because what that is he's having damage to the brain with tiny, what we call infarcts or strokes. It's not even a mini stroke where you have a symptom for an hour. It's like asymptomatic, and we don't see it until we do a brain scan. And what happens is they get an insult, as we say, so a little tiny stroke, or they get a flu or something like that, and their function goes down, but then they can stabilize. And so when you talk about symptoms, so very highly educated people, they often need the extra testing. We're going to talk about testing in a minute. But people with more than a college degree often needs extra testing, and we'll talk about that in just a sec. But symptoms of, you really described it, just not being able to do the things that they were proficient at. So if it was a driver, well, he drove a truck for 30 years and now he can't reverse. Or, well, my mom cooked every day for us and now I found the stove on. That's a disturbing symptom and a dangerous symptom, but that happens. The appearance, of, he's so disheveled. I've never seen him like this, and that's a big sign. And not wanting to bathe. I don't know what it is about not wanting to bathe. That's a sort of moderate to late symptom, but they don't want to go get in the water. Okay.
Yes.
And sometimes incontinence can be an early marker, not always, but I have seen that as sort of like a clue. That was sort of the only clue, and you kind of dig deeper and it goes into it. I'm not saying it's a cause, but maybe more of an associated symptom, and they had never been screened for dementia, so let's screen for dementia while fixing the incontinence at the same time. So it really is just a breakdown in the natural function, and that's why we always need a family member present or someone to really give us the history. Well, how was your mom and dad in their early life or their midlife as parents? Because we need to sort of know what's normal for them, what's their normal habits, versus is this really bizarre or not?
That's excellent. So you kind of touched on it, because I think, we talked about this a little bit about how dementia differs from normal aging. So, is it not normal as you age to have some decline in your ability to do some of these things we've talked about? And, that's really not normal.
I would say it's not normal.
Yeah.
I think that people, and this is when I get on my soapbox.
Yes.
This is an unrelated example, but I have to give it. I was in church and there was a woman, you knew it was going to be a testimony of being healed from cancer. Okay. But while she was telling her story, she said the doctor said that she was breathing like a 93-year-old woman. And I said, wait a minute. What does that mean? Like, a 93-year-old woman breathes normal, like, so we have to be super careful of our healthcare professionals. Remember, because we are making strides in getting it codified in medical school. There's been the Reynolds Foundation has been doing a lot towards getting our education up. But you have to realize that most health professionals have not had any geriatrics training whatsoever.
Correct.
And that they're going to have the aging stereotypes that they grew up with. So if they had a fabulous grandparent and great grandparent, and they yachted around the world, and they think older people should be like fabulous, and if they had really sick grandparents, they're like, well, everybody goes to the nursing home. So I think that's the other thing. You have to go in knowing that healthcare professionals have age bias just like everybody else. But to go back to your question, so yes, I do not think memory loss is normal. I mean, it's normal. You do have some slowing of, you have some slowing. Just like we do when we're really fatigued, right? 4 o'clock, I can't remember anybody's name. I cannot put a sentence together if I've not had my requisite hours of sleep. And I think people need to recognize that, so that's why even when they go in testing, it needs to be a good day. If it's a bad day, great. We can always repeat it, but just know that that's just normal. It's not normal to have cognitive impairment that affects your function.
Got
Okay.
it. That's the key,
Now,
y'all.
over the age of 85, it goes way up.
Yes.
It's only 5 or 6%, 65 and up. But when you hit 85, which is the oldest old, the prevalence is more like 1 in 3.
Wow.
Okay. But it can be very, very well managed. I don't, it can be well managed.
Thank you. These are such, I hope you all are catching this. These are such good pearls of knowledge, not just for the lay people, the family caregivers, even patients, but for the doctors
Yes.
as well. So I have had clients and family members and friends, and I'm in some of the caregiver Facebook groups, and you just see so much and hear about so much frustration with our colleagues. And the thing that I see the most is I'll get a client that says, I've been trying to get this addressed for the last 6 months, 1 year, 2 years. And so what advice do you have for a family caregiver who has a family member and they're worried about dementia and, they just want to get an answer? Do you have any recommendations for them?
Okay. I do. I think first of all, I think sometimes we're telling them the answer, and they're the caregiver is not yet. Okay, I have to defend my colleagues just a little bit.
Yes.
The other piece to that is, as we reference the business of medicine. Okay, we can't really. We cannot separate the two. So care of older adults and the business of medicine. So what you have to find is you've got to find a primary care physician who understands older adults and who is willing to put in the investment, because it is an investment.
Okay.
It takes longer to take care of older adults. And then the frustration, what is the frustration with? Is it with the medical care? Because when it comes to dementia, we don't have a lot of treatment, but I can tank you up. I said, let's go through these medicines. Do you need to be on these medicines? And when we start to take away medicines, you got to take it out that cold hand. Well, my cardiologist told me that to take but my lung doctor told me, and I'm like, okay, but you're 85. You're 88. Do you really need to be on a cholesterol drug? No. The guidelines say no. So no. So we start with that. The other part, I think the frustration with caregiving, okay, it really comes down to that, right? Is there a good social worker in that clinic to deal with the sort of, it is health care needs, but it is custodial care.
Yes.
So I need someone to sit with my loved one. Okay, medical insurance doesn't cover that.
That's right.
And so I think the frustration comes down to people are like, I need help, and they don't know where to turn. They don't have the funds to provide it. Mm-hmm. They may not even have the resources in the family, because again, our generation, and even my mom's generation did have a lot of siblings, and so this has been the bedrock informal caregiving.
Absolutely.
But now that we live away from our parents, and all of these things, some hard decisions and questions have to be made, and it often comes up with money. What I as a physician and geriatrician can do is say, hey, I want to see if I can get all of these things done for you. And so let's streamline your medicines. Let's kind of cut out some of these doctors. Let's have the social worker. Let's do home health, which is short term.
Mm-hmm.
If you're a veteran, they have lots of resources available to them. But when it comes to 24-hour care, that's largely still private pay.
Yes.
And that's what we have to deal with now while we're young,
Yes.
and for our parents and our grandparents, it's like we've got to plan now for the future, and that's just not something our culture does.
That's
Right?
right. We don't like to talk about these things. You're absolutely right.
And I think a lot of frustration comes in because we have failed to plan. And we have not planned financially. We have not planned as far as advanced care directives. It's time to ask. These are hard questions, but you need to ask your mama, and your daddy, what would you do?
Yes.
If you got cancer, would you want treatment? What does that mean? If you were on a ventilator and couldn't breathe on your own, would you want to be that way? So these are things that we don't like to talk about, but we have to talk about.
Absolutely. I'm so glad you brought that up, because a lot of families, particularly, I can speak for the African American community, not that nobody likes to talk about it, but we really don't like to talk about it.
Right.
And we know that these things are inevitable, death is inevitable, and yet we just kind of don't want to think about it or talk about it. And you're right, now more than ever, we have to have these conversations. We need to just sit down with our loved ones and talk about, like you said, their wishes. I love what you said about just simplifying their care. I have a family member now in her 80s, and she was hospitalized recently, and when I took her to her follow-up, I was in the hospital, and then in subsequent rehab, they just took her off of a whole bunch of her medications. And I was so thankful when her primary supported that. He's like, oh yeah, let's just keep, I thought he was going to add everything back on. And it just made her life at home so much easier, And I wish that we had advocated. I mean, my dad wasn't even that old. He was in his late 60s when he passed away. But he was on so many medications. And we know for a fact that some of those, like you mentioned earlier, were contributing to some of the symptoms. I did want to talk a little bit about diagnosis, because some of the frustration that I have seen from family caregivers is that they feel like they just can't get a diagnosis. I love what you said earlier, and I want you all to hear this. Dr. Sheppard said that some of you just aren't listening. So some of you have maybe been told that your loved one has dementia, but maybe that's not what you wanted to hear. And as she shared, there's not like a cure or a treatment necessarily. And so maybe you're looking for something else. But for those who really, maybe the family member is saying, I think this is dementia. Is there a definitive test? Is this solely a clinical diagnosis? How can a family member kind of get that reassurance that, okay, this really is dementia?
Okay. Yes. So what I want to say is that it is still largely a clinical diagnosis. We do not have a hemoglobin A1C,
Darn it.
Even with darn it, we don't have a blood test. Alzheimer's disease technically cannot ever be diagnosed unless you have a brain biopsy. And I don't know how many people are doing that after death to verify. So it is largely clinical. And so what the diagnosis generally has a really good, primary care history and physical. Let's document, let's go back and see, okay, when did you first notice the memory loss? What were the issues that were going on? Let's get a blood panel so that we can rule out the reversible causes of dementia. And this is why we always get a B12 level. We check for your thyroid, and there's a few others that we check. Let's look at the medicines. Are you having medicines that's the interaction is causing you to be cleared? A big one is depression. I cannot diagnose dementia if you have documented depression. Wow. Because it has to be treated first depression mimics dementia. And so our community also has issues with that. I'm not crazy. No, you're not. You are not crazy. But when you have, and it may not be the symptoms you think of feeling sad or whatnot, but some of the social isolation that comes with older adults, some of the things that they can't do the things that they used to do. And so they may have some underlying clinical depression. So we usually do a screening tool, and any primary care physician can do this. So many people have heard of the mini mental status exam. Most people now use the St. Louis University Mental Status Scale, or the MOCA, which is the Montreal Cognitive Assessment. And what that does is it looks at orientation, it looks at your speech patterns, it looks at your executive function. So we ask people to draw clocks and things of that nature. Can you do things in an orderly pattern? And then we do get some sort of brain imaging, so a CT or an MRI, because we want to screen for any vascular changes in your brain.
Okay.
Sometimes when people sort of have just the screener and the CT and they're like, oh no, it's all good, you got a 30 out of 30 or 27 out of 30, but they're a master's level engineer, then I would actually recommend, if they are having functional difficulty, a master's level engineer shouldn't be having problems driving, or paying their bills, then I do recommend going to get screened by our neuropsychologist colleagues, and they do the full battery of tests, because those screenings is just a screening. Right. Yeah. And so there's a full battery of tests, and they can locate and match it to the brain and say, yes, this is cognitive impairment, or no, we do think this is dementia, it looks Alzheimer's, and then you do a full battery. I know you mentioned someone was like, oh, it's not a diagnosis unless they get a lumbar puncture. That is a very invasive screen, and we sometimes get that, or the neurologist will get that to rule out normal pressure hydrocephalus, which can be a cause of a reversible dementia, can be, but that is definitely at the second or the third step. It's not something that people normally have to get.
Excellent. Wonderful. This has been amazing. You are just a wealth of information. I have learned a lot, which I always do. I know that the viewers have learned a lot. Do you have any resources that you can recommend, either websites or, for family caregivers and even healthcare professionals, if you're interested to get more information?
Yes, and I wrote a list here, and I did that breakdown. Let me open up my computer. So for healthcare professionals, I'm going to lead them to our association websites, which is the American Geriatric Society, and that's americangeriatrics.org. Mm-hmm. The lay professional version of that is healthandaging.org. And what I love about this website is that they have these tip sheets that can be printed off by the doctor or by the healthcare person. And I know you've been doing caregiving the whole month. There's lots of tips in there about caregiver burnout.
Wow.
What dementia is and what questions you should ask when you're at the doctor's office. Really good resources for loved ones who are already in an institutionalized setting, say a nursing home. I would say PALTC.org. This is AMDA, the Society for Post-Acute and Long-Term Care. So also for health professionals, there's wonderful education there, because this is an area, I will tell you, having worked in nursing homes, people hate the nursing home.
Yeah,
okay.
They do. I do.
Yeah. And the thing is, it's a place where the myths are all true and they're all false, and it really depends on where you go and the administration. One thing I would say is going back to the healthcare workforce, because we don't have a geriatrician. You know, that's what I say, enough geriatricians. That's what I tell people, like, hey, the myth is that geriatricians work in nursing homes, when that's not true. You know, I happen to be there, but most of the time you'll be treated by an internist or a family practice doc. It can be very medicalized. There was a whole movement to make the nursing home more home-like, and that was adopted with varying success or not success based on where you lived and what type of investment people wanted to put into it. I also wanted to, I'm looking for my document here. I gave you the big ones. I want to give a special shout out to the Veterans Affairs Medical Center. If you are a veteran, you know, more than likely there is at least a geriatric subspecialty clinic, or the social worker can help you with homemaker service. It's the only organization that I know that will provide homemaker services as a part of their benefit. Now, some of it service connected based, some of it is need based. But you can get someone just to come and sit, or just to come and you know, help meals or light housekeeping, very light housekeeping. The Veterans Association will do that. I'd like to give a plug to the caregivers. I'm sure you have said this a multitude of times, but please take care of yourself first. You know, I cannot stress, I have, you know, the statistics tell the story, but I have seen this over and over again. God bless wives. I've seen them have heart attacks. I have seen them be so burdened and broke down, and some people just won't even take the help, you know, and I'm like, please take the help. It's not perfect. It's not you. You know, I know it's not perfect, and I know it's not what you would have done, but your loved one is going to need you. And to do that, you need to sometimes get away and recharge.
Absolutely. Oh my gosh. Excellent advice. I don't know a better way to end it. I just think that is a perfect way to end the interview. I want to thank you so much, Dr. Sheppard. This was amazing. How can we find you? How can individuals, if they want to learn more about your consulting, how can they learn more about you?
Well, you know, I don't have the online presence that I should have.
Okay.
I am on LinkedIn, just under my name, Dr. Kendra Sheppard, or you can Google Sheppard Consulting. On Twitter under my name. But my website and business Facebook page is to be continued. I did want to shout out a doctor that I've seen recently on YouTube and LinkedIn, and it's Dr. Macie Smith, Macie. I don't know her personally, but she is doing some great things as it pertains to caregiving, so check her videos out.
Excellent. Thank you for that. Thank you for all of the resources, for your time, for your expertise. I am sure that this information is going to help others. So again, I appreciate you. You all share this video. I know you know someone who is taking care of an aging parent and grandma, a grandpa. Please share this information. As Dr. Sheppard said, the caregivers often suffer, you know, and so they need this information. Information, knowledge is power. So please share this video with others. And Dr. Sheppard, it has been a pleasure. Thank you again.
Thank you so much. Thank you for having me.